So in video 4, what we're going to be talking about is really looking at solving occlusal problems. And what I want you to see is how we can take some of the principles that you are learning about occlusal design, first recognizing occlusal disease, um, and seeing how we can apply these principles of occlusion to developing good treatment plans to not only help the patient biologically and structurally with the teeth, but also to be able to manage occlusal forces in a way that it will help them keep their teeth and keep their restorations in function for a long time. So one of the things that I want you to think about is that as we do that TMJ occlusal examination, we have really two possibilities. We can either go and have a negative occlusal exam, and if you go all the way over to that green light, if there are no signs of instability and that patient has a healthy joint, this is the person that we can work in their habitual occlusion or in their maximum intercuspation, their MI. The second option is if they have signs of instability but a healthy joint, in other words, a verifiable centric relation, this is when we can work in centric relation, in other words, seat the condyles and create an ideal occlusal scheme from there, meaning that their centric occlusion, in their centric occlusion, when the condyles are seated, everything fits together. And so if we have that scenario as they go into protrusion in left and right lateral, there's no ability to rub on back teeth. And if there's no ability to rub on back teeth, then we can create an occlusion that is ultimately going to have the least amount of force being able to be driven by the patient. So the patient can't create excessive force with their muscles. A third possibility is a tough one, and I know you've had some lectures about this, but if the signs of instability are related to the joint, where we're completely off the disc, particularly off the medial pole, or there's active degeneration going on, what we call degenerative joint disease or DJD, then we would call that a non-verifiable centric, and these are the patients that we're going to have to treat the joint first and get that joint stable. In my practice, we do a lot of splint therapy first to get these patients stable before we can then start reorganizing their occlusion. So when we are treatment planning these type of patients, we're going to be doing it with a series of photographs and, of course, mounting our models in centric relation on an articulator. If it's a TMJ patient, we would get the joint stable first and then mount the models in what we call adapted centric posture in the Dawson vernacular. But to be clear, we are not mounting models until we're sure we are comfortable with the joint position. The other thing that I want you to think about is there's a rule that Dr. Dawson has taught me called the Whittiam rule, which basically means would I do it on me? And when you're doing this type of dentistry, it can some camps will advocate sort of full mouth reconstruction on everybody with a bite problem. But I want you to think about this rule, would I do it on me? And in our philosophy, we want to do the least amount of dentistry to be able to solve the problem. And then remember our treatment options, we can reshape teeth, we can reposition teeth, we can restore teeth, and we can reposition bone. We can do orthodontic surgery. So we want to figure out how to do the least amount of dentistry on the patient. If you look at our sort of 4 food groups of treatment planning, we have aesthetics, we have function, we have biological health, and structural integrity. What I want you to think about is those bottom 2 are really related to individual teeth. And the top 2, aesthetics and function, are more global positioners. We're thinking more in terms of the entire system. Aesthetic dentistry is really about figuring out where the teeth are going to be look the best within the patient's face, and then move closer and get your contours right and your embrasures and all those things. It's the same thing with occlusion. We want to first be thinking about it from a macro level in terms of how the upper and lower jaws relate to one another in a stable seated position, and then figure out how the cusps fit together and work out your disclusion. The top 2 there, we're going to be making a lot of decisions by looking at photography as well as our mounted diagnostic casts. The Wizard is a tool that we use at the Dawson Academy. I'm not going to give you too much about this, but it is a way for us to analyze our photographs. And so in our protocol, once we take our photographs, we can take it into the Wizard, and we have a series of questions that we go through to analyze where the teeth are going to go. And so trying to find the right position in space, in this case we're liking the position of tooth 9, and then treatment planning from there apically, we can start to see maybe where the gingival tissue should be. And then we can start thinking about what is going to be the best way to get that done. Is that through orthodontics? Is it through crown lengthening? But clearly, having a protocol to analyze what you're doing is what you're going to want to be thinking about. And again, some of this goes beyond maybe nuts and bolts of what you're doing in dental school, but if you have the desire to treatment plan and handle more complex cases, you can't just go from one teeth and start treating 14 teeth. You start doing 14 teeth, there is much more analysis that has to go into it. And my point to you with all this is your training on occlusion actually, believe it or not, prepares you for some of this. The only other thing we're doing is really adding the layers of some of the analysis of photography to be able to figure that out. What we're trying to do is get to a point, and this is what's happening in the software, where we can start to figure out the size and shape of the teeth. And here you can start to see where our incisal edges are going to be. That right side needs to come down. The tissues on the left side need to come up. And we have the ability to even do subtle analysis of that. And notice on the left side it's showing specifically the size and shape of teeth. We do our analysis two-dimensionally like this to be able to then communicate with the laboratory to be able to give us a diagnostic wax-up that's going to be appropriate for where we're going. So the other thing we can do is take these contours and create a mask that allows us to bring these two shapes into their full smile and full face. This becomes a wonderful tool for us to be able to communicate with our patients. So I want you to think about that this protocol is what we do with aesthetic design. Photographic analysis following smile design principles to figure out where we're going. And taking this data and then working with our articulator then allows us to start looking at occlusal design. And so if it's a case like this where multiple things are wrong, or if it's just a simple equilibration or an Invisalign case, the goals of creating lines in the front and dots in the back, no ability to rub the back teeth is what we're after. And so that's really what I want you to see. Knowing how to adjust models, mounting our models in centric relation, and then figuring the most conservative way to make all the teeth to come together in that joint position is a big part of what we do. And so this is why we have to work with an articulator, is that when we're going down this realm or this road and really starting to solve an occlusal problem on somebody whose bite is not working, these are some of the things that we do. We can reshape teeth by removing tooth structures, and as I'll show you in a second, we can also add to teeth by adding wax. And when we go to the mouth, we can of course add tooth structure with composite resin, or we can add tooth structure with porcelain. And so this becomes our way to visualize, in this case, a case that it's going to involve a little reductive reshaping in the back and a little additive reshaping in the front. This is what occlusal design is all about. In the next two videos, I'm going to show you some cases in detail of how we work these things out. That's the earmarks of a good occlusion. Just showing me that I can do some simple equilibration as well as some bonding up front to go where we need to go. So as we go back to our little flow sheet here, if we look at the patients that have possible occlusal exam, let's look at the type 2 first. And again, the signs of instability are going to be wear, mobility, migration, sore muscles. They have a verifiable centric, so our goal is to work in centric relation and create the ideal occlusal scheme from there. And our goal then is also to choose the most conservative treatment option or options to establish occlusal stability. And our 4 treatment options are going to be reshaping, repositioning, restoring, or repositioning bone, and building in those requirements of occlusal stability, stable stops in centric relation on all teeth, non-interfering posterior teeth, and then an anterior guidance that's in harmony with the envelope of function, things that we have discussed. So we'll look at the reshaping option, and we're going to look at these patients in a little bit more detail. But if we have a scenario where in their mounted models we don't have good coupling in the front, and the patient can rub on their back teeth and they have some signs of instability, learning to equilibrate or adjust the back teeth to get them out of the way, learning to hold the jaw in centric relation so you can see those markings is a big part of what we do. And again, knowing where to adjust to eliminate those posterior interference is what the reshaping or equilibration option is all about. When you get into to the clinic, you're going to be doing some of this, and initially you're just going to be learning to equilibrate on a single tooth so it fits within the patient's bite and the patient's maximum cuspation. But as you evolve, or should you evolve to do more complex situations, you're going to be learning how to equilibrate to centric relation. And then that's when we really can start to have control over the system. Repositioning, and again, there's some people whose primary problem is just a tooth position issue, and we simply can't get this done. This is a case that Doug did with his periodontist. He'll probably talk to you about some of the dental-alveolar distraction osteogenesis, which is a case that procedure that involves rapid movement of teeth through additional surgery that can be done by creating these corticotomies. But what I want you to look at is, again, how the teeth fit together, how we have good stable stops in centric on the canines, and how the patient has good disclusion. So the orthodontic option, I think, is not used enough in general practices. I do think Invisalign and some of these other things is changing that because we see it more now. So repositioning is important. In restorative dentistry, we have to remember, particularly on aesthetic cases, you can do, beautiful smile design work, and that's fun. This is a veneer case, but if we want it to last, we have to have just as much attention to detail in the occlusal design. And so these cases are all equilibrated first to centric relation, and then guidance is designed prior to figure out how we're going to transition from enamel to porcelain or staying completely in a porcelain. And then sometimes we have patients who skeletally just don't allow the front teeth to contact properly. And this is one we'll look at later, show you why he has such a large skeletal discrepancy. But in his centric relation, this is how his teeth fit. And the only option that could get him fixed is orthognathics, by bringing his lower jaw forward. That's going to improve his face, but it also helps us to create those requirements of occlusal stability that you're learning about. So those are the treatment options, and I think what I'm going to do is go through one more, and then we'll go through some detail. So when you've got a patient that has everything going on, skeletal problems, in this case over-contoured crowns, nothing really lines up, sometimes it requires all of the disciplines. And this is a patient that was going to require some removal of all those restorations, some periodontal surgery because she had 6mm pockets, some orthodontic treatment, some orthognathic surgery, and then restorative dentistry. But notice, with all those disciplines going on, we're still starting on an articulator with a good three-dimensional plan. And so orthodontics is done, jaw surgery is done, setting me up to do what I need to do to be able to give the patient a result, it's not only going to show nicer features, better balance in her face, but also really good aesthetics and a situation where we have coupling up front, we have equal intensity contact and centric, and no ability for the patient to rub on their back teeth. All of these different treatment options, from something that's fairly simple to something that's very complex, the common thread is the occlusal design. And that is what I want you to be thinking about right now. Last possibility is when you have a bad joint. And when you have a bad joint, the two treatment option is either splint therapy, which is the most conservative option, or some sort of surgical intervention to the joint. And honestly, we try to stay out of the joint as much as possible. I have really, really good success treating patients with splint therapy and getting them comfortable and letting the joints heal, not like to get a joint back when the patient's 15, but to a point where it can be stable again. And so patients like this that have clicking and popping and limited range of motion and pain and loading, crepitus in both joints, cone beam confirmed active degeneration, worse on the left. She has bilaterally displaced discs without reduction. This is a patient that's going to require some significant intervention by us. Here are the cone beams, and we're basically going to be doing a permissive splint. And her splint therapy took a year for us to get stable. And Dr. Maddie's going to be talking to you about how you know when a patient is stable after splint therapy and it's safe to move on to the phase 2. But what I'll tell you with these type of patients is that as their joints break down, they become more class 2. The jaw tends to come back. And so this is a patient that had to go through orthognathic surgery, equilibration, and a couple of implant crowns. And what I want you to see here is notice the balance in her face. Notice how we have a return to cuspids in a class 1 relationship to protect the posterior teeth and decrease muscle activity. And all I really did in this case was, at the end, was a pretty simple equilibration and restored some implants. But I love this case because I knew what was going on, and I had the team in place to be able to work together to be able to take her where she needs to be done. So phase 1 was getting the joint stable. Phase 2 was treating the bite. And so there's our grid. Every one of your patients is going to fit in one of these categories. And the key when you get out and start practicing is making sure you got the patient categorized properly, because you're going to have a different protocol, treatment protocol, depending on which category you're in. So let's look at one example in this video that is a little bit more simple. And then when you come back and look at the last video that I'm going to do for you, is we'll look at some more complex treatment options. And so you can kind of see the gamut. But again, keep in mind that while the treatment modalities are changing, our treatment goals, occlusal goals, do not. So this is Ben. You looked at him in the first video when we talked about signs of instability, and I want you to notice the size of his masseters and also notice some of the wear and tear that we'll see on his teeth. He has high aesthetic concerns. He's got a history of some clenching and grinding and some soreness. He does have a lateral pull click on his left side, but his biggest concern is the wear and the exposed dentin. He does have a problem with some wear and obstructive sleep apnea. He's got a normal load test, but it's tight. But as we say, the biggest sign of instability that we're concerned about is the wear. Remember, if you can see dentin, and if you look at his top teeth there, these have been restored several times with resin already, and they're failing. And I think the reason they're failing is because all the dentistry is just being done in MI, and they're not really looking at the interferences in the back. If you can see dentin, the patient is lost. a minimum of 2 millimeters of tooth structure, and the wear is now 7 times faster. So this is a sign of instability that's going to continue to get worse. And what he doesn't like about it is it's also looking bad. So as we see some of the wear, we see the concave type profile to his lower incisors. You can see the distal of his laterals and the tips of his canines wearing. Again, for somebody that is basically 50 years old, he's going to continue to get into greater trouble as he gets into his 60s, 70s, and 80s. So we're going to look at him and go through a process of figuring out how we're going to solve the problem, and then talk a little bit about sequencing. So remember, as we think about our treatment options, we have the reshape, repositioning, restore, and repositioning bone. And we're going to go through a checklist here that is part of our wizard. And again, you may not get into this much detail, but I just want you to see the logic behind what we do. And of course, the first things we're going to look at is the 5 requirements of occlusal stability. And on-mounted models on an articulator, we're going to ask, are there stable stops on all teeth or a substitute? And the answer to this question is no. You look at that top right picture, it appears he has an open bite. He's only hitting on the back molars, and then he sort of slides into his MI. So he has the ability to rub on back teeth. The second thing is their anterior guidance and harmony of the envelope of function. Well, if he's only hitting on back teeth, there is no anterior guidance. So here again, I'm thinking that I may be able to reshape those back teeth and maybe restore the front teeth and get him back into harmony. But as you'll see, we'll actually do that on the articulator in a minute. All right, we go to the next one. Do the posterior teeth on the balancing side to exclude. And this is where you can really see the back teeth rubbing. You see the buccal slopes of the upper lingual cusp rubbing against the lingual slope of the lower buccal cusp. This is one of the most damaging types of wear patterns that we see. And again, just looking at his disclusion, just right and left lateral, slight wispy lines on the lingual slope of the upper buccal cusp, but most of the disclusion is on the balance off of balancing inclines, and that is why he's wearing things out. So when we go to our 3D workup, here again we have a checklist to figure this out. And the first thing we're going to do is make sure our casts are mounted in centric relation, which they are. And then we're going to really design our occlusion by first looking at the lower incisal edge, then looking at our upper incisal edge, and then deciding on our vertical and our stops. So let's talk about that. When we look at our lower incisal edge position, what I want you to notice is the position of the canine in relationship to the lateral and the premolar. And if you were to just add a cusp tip on that canine, how much higher it would be out of the plane. And what I want you to think about is as that canine is wearing, it has erupted. So what we can do when we do our workup and do our design is pay attention to those buccal cusps posteriorly and make sure that the tip of our canine is going to be in line with that. That prevents us from making the lower incisal plane too tall. It should be in harmony with the posterior occlusal plane. So I'm going to be reshaping the canine and making sure it's in harmony with the premolars. I'm going to thin out my lower incisors a little bit because they get fatter as they wear. And then we're just going to take some wax and just start waxing a plane that is more straight. We don't want, lower incisal planes should never be concave. They're either straight across or they're convex. And so I'm doing this right now, just eyeballing it right off of the articulator, or the lower cast off the articulator, and just creating a good plane there. Upper incisors, we make a lot of our decisions on upper incisors from the smile design, which goes beyond the scope of this lecture. But if we can figure out, looking at photographs, where the incisal edges should be, we have some key photographs where we make that decision: the smile, the rest position, the E position, and the profile smile. We can then do a similar type design, and we basically want to create something that's going to be fit nicely against the lower lip, follow the curve of that lower lip. So here again, when you look at the cast, you can see the centrals might need to be a little longer, but we really need to add some length to the distal of our laterals, to the tips of our canines, and to create some embrasure patterns here that are going to look nice. And so here again, with our little electric waxer, we can do some of those things. So notice, even before I start looking at our occlusion, I'm getting my front teeth kind of where I want it. And this will help us later when we start going through excursions. The next thing we're going to look at is decide on vertical. And there's two ways you can do this. When you're looking at your cast in centric relation, you can either restore or do your ortho or do your procedures at this vertical, or you can see, if you were to reshape the teeth in the back, could we close this patient down and have everything line up? And we call that reductive equilibration. We're going to do reductive most of the time because it decreases the amount of dentistry a patient needs. And that's a good thing as we follow that Whittier rule. So to know if we can equilibrate, we're going to take our lab articulating paper and we're going to start adjusting the cast. And we're going to do this by grinding on the sides of the stamp cusps. Again, notice even with our incisors waxed and our canines waxed, patient still doesn't have posterior disclusion. They're still rubbing on back teeth. And this is a great example of why we need to get the posterior teeth equilibrated. Because if you were to go in there and just bond the front teeth, and he can still rub on his back teeth, muscle activity is still going to be high. So this is why we do this. We're going to equilibrate it so that when he slides around, there's no ability for back teeth to rub. So now, as we read this and start our trial equilibration on our cast, remember that we're going to grind on the sides of the stamp cusps. The stamp cusp is a cusp that fits into a fossa. So your upper lingual cusps, your lower buccal cusps are the stamp cusps in an occlusion where there's not a crossbite. And notice when I'm doing this, I don't wipe the whole mark away. I always leave behind what we call a remnant, which is basically a little bit of the mark where you want the contact to be. So we're taking away all the marks on the inclines, and we're going to leave behind a small mark either on a cusp tip, marginal ridge, or central fossa. Cusp tip, marginal ridge, or central fossa. And as we adjust those back teeth, the articulator is going to close down a little bit more. Now it's starting to look good. And this is a good example of, because the restorative dentistry is going to be needed to be done up front, we can close this patient down to the first bicuspids. And if we're still slightly out up on the canines, then we can come back in and wax this in. So we're doing some reductive reshaping in the back and a little additive reshaping in the front. And if you think about this, you could do the same thing in somebody's mouth by reshaping the back teeth and just adding resin in the front, which is what we do a lot, particularly with patients that have limited funds. All right, so once I've kind of dialed all this in, we created my appropriate posterior exclusion. We can now harmonize that anterior guidance. And by doing this, we're just making sure that there's no ability for the patient to rub. And now we can start to see all those good things going on. This is what we want to see. If you want to do a little final check just before you show the patient, we can do that as well. A lot of times I'll send this to the lab and get it cleaned up and get it presentation ready. So when we start treatment planning a patient like this, the things that you've learned about biologically is always going to be the first thing that we do. Eliminating pain, emergency concerns, root canals, caries control, home care instructions. But stage 2 is when we're going to do the things to get the mouth stable occlusally. TMJ patients will get splint therapy. Sleep apnea appliances happen here. Equilibration happens here. Provisional restorations happen here. Orthodontic surgery, ortho. And then stage 3 is when we would do the definitive restorative dentistry. What I want you to think about is somebody with occlusal disease, you want to make sure you've got the patient stable biologically and functionally before you start doing your crown and bridge. Otherwise, you're just going to be rebuilding the occlusal issues into the patient's final restorations. So with Ben here, we're starting with basically periodontal scale with inflammation, perioprophy, some home care instructions, and a couple of resins. In stage 2, we're going to be doing an occlusal equilibration along with resins on his anterior teeth, 6, 11, 22, and 27 by additive equilibration. And then as he is ready in stage 3, we can be doing some of the anterior work. And the plan is to do some veneers on his lower incisor, canine to canine, some crown work, conservative, all ceramic restoration 6 through 11. And then we've got that one crown with fractured porcelain on 19. And we can do that not all at once, but in phases as he needs to. All right, so let's just go and look at the things that we're going to do first, which is getting the mouth stable biologically and functionally, which is our immediate concerns. And then we can mention how the final restorations can be deferred over time. So what I want you to see is that if we've done the wax up on the articulator, how easy it is to get the mouth stable. And I'm going to take you to the appointment where we're going to be doing the resin work and the equilibration. And we're going to follow this in the exact same order as we do in the articulator. We're going to bond the lower incisal plane, bond the upper incisal plane, and then equilibrate them. So notice what we do. Because we have done a wax up, I can make a silicone index of exactly where the incisal edges are going to be. And then we can take a small quarter round burr and a diamond, and we can do literally an injection molding technique into the patient's mouth. And that way we transfer what we've worked out on the articulator right on in. Want to make sure we have a chamfer, and want to extend on the facial and lingual so we can grab. And then we're going to do these teeth 2 at a time to prevent us from bonding all this together. So we're using phosphoric acid. In this case, we're using some 3M products. So our bonding agent, a 5th generation bonding agent. And we'll air thin that, cure it. Make sure you get the composite down into the dentin. It completely seats. And once you've got it initially going, then what we're going to do is take our matrix, get it back in place, and then we can inject that on in. We need to add a little bit more. Or we can literally take our Explorer and start opening the facial embrasure, because the lower incisors really don't have lingual embrasures, just deep facial embrasures. Those can be cured, and then the others can be done. We're going to do the same thing with the upper. Try our matrix in, and you can see where we're going to add. So we'll prep into that, etch, single bond, and go through the same process so we can bring those edges in. Now we're going to go and do our calibration. So our edges are taken care of. Okay, so you can see, haven't polished anything yet, but the upper and lower edges will be taken care of. And using Dr. Dawson's bilateral manipulation, we will hold the patient in centric while our assistants hold the articulating rhythm, and we will mark those interferences. And just like on the articulator, we're going to be grinding on the sides of the stamp cusps, carefully reshaping. Remember, a stamp cusp is a cusp that fits into a fossa. So your lower buccal cusp, upper lingual cusp are the stamp cusp. And as we adjust, you're going to start to see more and more teeth forward coming in. And just like on the articulator, I'm going to equilibrate until the first bicuspid comes in, get my dots where I want them, and then we'll come in and start bonding. So I end up having to bond about, I think, 4 of the teeth. So we use our etch, single bond, and then a microhybrid resin. We're experimenting now, rather than just freehanding it, with clear putties, which allow us to do this even better without having to bulk it up and then grind it in. This is how I was doing it back then, which still worked fine. And again, you can kind of seed it and then cure from the facial, but with clear matrix, it works even better. But now what we can do is, once everything's touching, is really start looking at our guidance. And now we can get in there and make sure that we have no ability for him to rub on back teeth. So remember, in centric, we want equal intensity contacts all the way around, and then we want exclusion and protrusion, and left and right lateral, and the last is just making sure he's in harmony with the umbilical function. These little enhanced cups allow us to smooth everything. As if you lean on it, you can actually change contour. But any tooth that's been adjusted with a finishing diamond or a carbide, you just want to make sure you polish everything up. So as we look at him, what we've been able to do is create a biologic and functionally stable base prior to the cosmetic restorative phase, which is where we start to do the glass. And this gives us a period of time to make sure that things are going to work out for him. Again, noticing his excursions now, no ability to rub on back teeth, and because of finances and things, he had to wait a little bit of time to proceed with definitive work. But I like that, because the fact that almost a year went by and no resin broke and he was comfortable and headache-free and all that tells me that what we've done for him is successful. And so as we transition him into porcelain, which what he wants to do for aesthetic purposes, that we're going to be very successful. Now, what if he didn't want porcelain? Would this be good treatment? Absolutely. This could last a long, long time for him. You may have to periodically replace a resin if the canines wear a little bit, because they still do some of these functional movements, but it's going to wear at a very low rate. Why? Because when his back teeth don't contact, remember, muscle activity is lower. Now, when he was ready, he wanted to start with the top teeth. That gave us I can't remember if it was 12 or 18 months to get his tissues healthy, and he was seeing our hygienist regularly, and when he was ready and had the financial capacity to move forward, we could go ahead and just do our definitive work. I like having time to get the tissues pristinely healthy. And the other thing, we know exactly the contours we're shooting at. So, doing a provisional will be very easy. I can check my my reduction from 3 planes. Get really good retraction and a really good impression. Now, as you'll see, you guys had a exercise where you made a custom incisal guide table. The reason you make a custom guide table, this is something labs will do for you, but remember the lingual contour that you've worked out, either in the resin or in this case the temporaries as well, if that's the contour you want, the lab cannot see that from just a prep model. So by giving them a model of the lingual contour you want, which remember is steep enough to exclude the back teeth and still in harmony with the envelopal function, by giving them that, they can create the custom guide table and duplicate that contour for you. We can also do that digitally today, because if we give the lab that contour, they can scan your temporaries, scan your dye models, and superimpose the provisionals right over. We call this digital duplication of the anterior guidance. But however you do it, we want to make sure that that lingual contour is precisely what you have worked out on the patient's mouth. And when we do that, we'll get final restorations back that will look great. And so this was the first step for Ben. He's since done the veneers on the lowers as well and replaced that single tooth back there on 19. But again, what I want you to just appreciate with this is a case that you could have easily stopped and just done with the resin and successfully handled this patient's occlusion. But this is also a great way to sequence a case and work with a case that may be a little bit more advanced. What you don't want to do is, on a patient with occlusal disease, is just start prepping teeth and hope the lab can somehow fix it. Generally, when you do that, you're going to just keep duplicating the occlusal errors, and you'll be frustrated because patients will be breaking temporaries and teeth will be changing positions, and the case goes back and forth. So learn a protocol, follow a protocol. Start learning this, and then when you get out, keep studying it. There are places to go, and certainly the Dawson Academy where we do our teaching is one of them. So I hope they find that interesting. In our 5th video, we're going to be looking at cases that are even more complex. So have a great day, and we'll see you in the next time.